So at first I will give you an overview over the TOPS system history. And the TOPS beginning in 2005 was the first generation device here on top, and followed with a third generation. With a third generation device. It's the big advantage that this in device today, it's smaller, so a total laminectomy is not still necessary. So from our point of view, we let the lamina in place, so it's not necessary to remove normal anatomical structures, and it's only necessary to remove the processus spinosus and the interspinosus ligament. So that's, from our point of view, it's very good. So it followed with the hybrid solution, as Dr. has showed before, and continued with a new kind of device with some new rods with more possibilities. It's a little bit easier to handle it here on the screws where you continue the device. So the revision rate of the first and second generation device was 5.6% overall devices, and 1.2 in the third generation in all clinics. And this image here shows you that it's very controlled and not to overflow clinics with this device. It's very important to start with not too much surgeons who offer patients this device, and it started in Israel with a third generation device and followed with the countries named below. This is the total amount of devices implanted for the third degeneration. It's 35 and in Israel and 32 in Germany, and not so much in the next countries. So the cases are 61 with TOPS at a single level and 23 with a hybrid solution. And we start with the first case in 2012, and at the moment we treated 17 patients with a TOPS or with a hybrid solution. The philosophy, this is the second part of this talk, the philosophy of our center is to preserve motion wherever it's possible. And so I will give you a short overview from our philosophy and how we treat patients, because it's very important because of the standing of the TOPS implant in hybrid solution with other devices, not only with a fusion. So in our center we do a large amount of total disc replacement from an anterior approach, nearly 150 M6 per year. And here are two examples what we do in our center. The advantage of the anterior arthroplasty is the access without a muscle trauma, the very fast recovery of these patients, and we never saw facet joints problems with the M6. We saw it in the past with the Pro disc or with other artificial discs, not with the M6. That's very important. I will show you later on. This implant allows a lot of motion, the extension, flexion, the side bending, and the axial rotation. The disadvantage is very clear. It's not so easy to do a revision surgery if necessary. It's not so often, but it's possible, and it's normally not possible with a spinal canal stenosis, especially in patients who have clinical symptoms from spinal canal stenosis, and the listhesis is still a contraindication for an artificial disc from an anterior approach standalone. So the next one are the facet resurfing implants. We share these implants for the addressing of the facet joints in two groups, the resurfing and the resurfing implants. Here are one example. It's the Cyrus system from Spinal Elements. It's The big advantage is that you can treat the patients minimal invasive with target instruments. The disadvantage is we have no long-term results of this technology, and this implant is very easy to use in a cadaver lab or in a model, but it's technically very demanding in situ in real patient. The next one are the facet joint replacement technologies, like the TOP system or the Arcadia system from Globus, that are the only both systems in the market which shows still a benefit for the patients. The Arcadia has a big problem. It's not combined with a fusion on top or below. That's the problem at the moment for the company. The advantage, it's a possible technology with a spinal canal stenosis. It's possible with moderate listhesis, we saw it before. And I told you a laminectomy is not still necessary with a third generation implant. The disadvantage is that in the normal case, the facet joint replacement is not possible with a relevant disc degeneration like Firman grade 4 or 5. And at the moment, this maybe can change, but at the moment, only one facet joint replacement is possible. And sometimes you get problems in very small patients, especially in small women. And keep in mind, this implant is very, very difficult to implant in the segment L5 as one. Dynamic screws, you know it, do it a little bit faster. The advantage is an easy and fast technology. In the event of an spondylolisthesis, an implant failure is not so often like a rigid screw without a spondylolisthesis, like a cage. The disadvantage is it allows only the flexion, but the side bending and the axial rotation is not possible. And from our point of view, the long-term results are not convinced in most of the patients, especially if you have a severe degeneration before starting the first surgery. So only for the completeness, it's the nucleus replacement. At the moment, there are no convincing implants. Before, there was an implant in the market from DDI. At the moment, it's not available. All hydrogels are not worked and have no good results. And other implants, for example, the Nubak system, remains to be seen. The advantage is it's a minimal invasive procedure. It's an implant which is applicable in young patients, especially it's an implant to gain time. That's very important for very young patients like 20 years or a little bit older. The disadvantages, the better, as a matter of sum, the better the implant, the more difficult is the implantation. And the dilemma of this patient is there's a very rare indication because most of the patients who will have a benefit from only from a nucleus replacement have not so much pain that they underwent in surgery. So now this is very important. We in our center see the indication a little bit different to other centers. From our point of view, the best indication for the system is a spinal canal stenosis without an instability in very young patients, because from our point of view, the young patient with a spinal canal stenosis had a microinstability, and the microinstability is the cause of the disease. And if we do only a decompression, so we treated only the symptom but not the cause. And so from our point of view, it's very important to treat this patient at the moment, or still now, with a fusion and now with the TOP system. The second best, but a very good indication, is the spinal canal stenosis with a moderate spondylolisthesis, degree 1, or a facet joint hypertrophy in the classification of Fujiwara, degree 2 or 3, with chronic low back pain, with or without leg pain. And there are some special cases I will show you later on. There are various indications in the context of hybrid solution. That's very important for the group of patients we treated. Maybe in 360 motion preservation technologies, which from our point is only possible with the M6 because of the center of rotation. The center of rotation is very similar between the TOPS and the M6 system. it's not the same with other, for example, with ball socket disc replacement systems. Relative contraindications, multiple former surgeries because of the scar tissue. So our philosophy is to fix the segment with a fusion. Erythrolisthesis is not so good contraindication, and I'm sure this is for all of you very clear. These are absolute contraindications for this device. So what we're talking about the same, that's the MRI classification of the spinal canal stenosis. That's the classification we use in our center, and the classification of the listhesis is very clear, and we talk about these patients, not about the other patients. So I will show you at the last part of this talk some examples. We start with normal patients, as all of you treated as well, maybe. So this is a moderate listhesis with a patient who is had no benefit from a conservative treatment, is not so much in the MRI. She had a very good improvement from the surgery. The next one is a severe spinal canal stenosis or type C spinal canal stenosis with listhesis in L5, and that's also a very clear indication for a top system. It's also an indication for a fusion, of course, but the rest of the spine is very good, and from our point of view, this is a very good candidate for a motion preservation technology. The next one is a severe degeneration in 4-5 in the segment, and spinal canal stenosis in 4-5, and moderate in 3-4, and this is a very good case for a hybrid solution with a fusion below and a top system on top. So I show you especially this case because there's a little bit of displacement of the top system, a little bit below the midline. That's not so good, and we offer the patient an early revision of this implant, but the patient was very good after surgery, nearly pain-free, and the guy decided to let the implant inside, and in the follow-up he's still good and have no pain, and no leg and no back pain, and so we let the implant in place. So these are the CT scan after the surgery. Before I show you the more provocative slides of this talk, that's very important that I show you most of the things we do is the normal treatment. That's very uncommon here in the segment TH12L1. It's not so easy to handle, and it's not a case for a beginner, but the normal TOPS procedures we do is in 3-4 with TOPS, in 2 cases TOPS alone, and in 2 cases with a VersaLink, and most of the cases are in 4-5, like 8 cases here only with a top system, and 10 cases with a fusion below in 5S1, and only 1 case on top in 3-4. And we do provocative hybrid solution, I will show you later, in only 4 patients, but that's the possibility the top system could offer us in the future, not in your first cases. And keep in mind this is unusual and it's provocative, and it's only a very small part of the supplies. So this is not so uncommon. This was a patient who had an ALIF procedure standalone in the past, and a few years later he gets a moderate spinal canal stenosis with progression, and he wants to have a surgery for this because of the failure of the conservative treatment, and he gets a top system on top over the fusion in 5S1. So the next case is a patient from the US, and in our US patient it's very difficult because the patient wants to have under all circumstances a motion preservation technology, and so we have to offer the patients these technologies if it's possible, only if it makes sense, not otherwise. This was a patient who had a severe degeneration in the segments 4-5 and 5S1, but no degeneration in the segment 3-4, but a spinal canal stenosis type C, and this is our solution. He had a mixed clinical symptomatic of low back pain and leg pain. The leg pain was an L4 syndrome, so this was clear that the leg pain comes from the segment 3-4. So the next examples are other hybrid solutions, like this case with a degeneration in L3-4 and spinal canal stenosis in L4-5, and in this case we use a lateral artificial disc from Novasiv because of former surgeries of the stomach of this patient, so there was a contraindication for an anterior approach, and so we use a lateral approach. Normally we use the lateral approach for an artificial disc in 3-4 over an anterior approach, but not in this case. This patient has a very good recovery from leg pain and back pain, and she is still pain-free. And this is another case from a patient with a severe degeneration in L5S1, with a listhesis in L4 with a severe degeneration, and with a moderate spinal canal stenosis in L3-4, and so this is also an uncommon hybrid solution. So the next patient was a 50 or 55-year-old woman from the US. She wants to have also a motion preservation technologies. Her pathology was very complex, so she had a long-curved degenerative scoliosis, moderate, and a severe degeneration degree 5 of the Firman classification in 5S1, and show a moderate listhesis in L5. And the pain was dominant for the segment L5S1 with an S1 radicular pain and with a total memory pain in L5S1 in a discography. And she had two kind of solutions. The normally solution we offer the patient is a long instrumentation and correction of the scoliosis from TH10 to S1. But she told us, no, I will no long instrumentation. I have the pain only in 5S1. Please offer me another solution. And yeah, we discussed the problem and discussed with her that she gets only a surgery in L5S1. And expressly stating this doesn't meet the guidelines. That's very important. And this was the first patient to get a 360-degree arthroplasty with an artificial disc from an anterior approach and with a top system on top, both in L5S1, and she had still no S1 symptomatic in the leg, and the back pain she had a large benefit from her back pain. So I have one case for you. We have not the patient has no surgery at this moment. He sent us the pictures, and we saw the patient in Canada. And in this case, it's the question: is it a case for a TOPS or not for a TOPS system? The symptoms are very clear. It was a male. It is a male, 52 years, with a claudicatio and a radiculopathy for L4. That's clear, with a severe back pain, and we can't decide which level brings the patient the back pain. Is it the level 4-5 with a severe degeneration? Is it 3-4 with a listhesis? Is it both segments? And the ratio from the back pain to the leg pain is 60 to 40%. And this patient wishes a motion preservation technology if possible. And so in 3-4, this is the listhesis is too much for a top system, and also the severe degeneration with a complete loss of the disci and the segmental kyphosis. That's not a good case for a motion preservation technology for sure. And that's a clear contraindication for this. And this segment is only to address with a PLIF or an RLIF or a TLIF procedure. In L4, L5, and L5S1, there's a severe degeneration with a complete loss of the disci, less than L5S1. There's also no indication for a top system. And in this case, you can offer the patient a PLIF, an R-lift procedure, or a total disc replacement from an anterior approach. The facet joints in the axial images are good. And in 3-4 shows the patient a moderate spinal canal stenosis and no disc degeneration, no instability. This is a good level for TOPS, and so we offer the patient an anterior cage in 3-4 and an artificial disc in 4-5 and 5S1, and a decompression in 2-3 and 3-4 with pedicle screws. So overall a TOPS device in 2-3 and a motion preservation technology in the both lower levels and an R-lift procedure in the segment L3-4. Thank you very much.